So just by way of closing and to generate a little bit of interest in discussion about this case, as you noted, the patient had gynecomastia, and as Dr. Van Hurley, Dr. Gaffner pointed out, that was a little unusual given that we were thinking perhaps about elevated prolactin. And despite what many of the books still contain, including the endocrine textbooks, gynecomastia does not usually occur in the setting of hyperprolactinemia, and as Dr. Van Hurley said, is usually an estrogenic effect. The most common cause, as you can see, is peripubertal gynecomastia, which can be bilateral or unilateral. There are a number of drugs, and increasingly we see patients on the endocrine service who are taking herbal medications that have some estrogenic-like effect. Cirrhosis due to the inactivation of estradiol and reduced testosterone can cause gynecomastia. And then, of course, there are a large group of patients for whom there isn't a clear etiology. And other rarer causes include hypogonadism, testicular neoplasms, hyperthyroidism occasionally, and renal failure. So again, to this question of prolactinoma and gynecomastia, typically they do not have gynecomastia, and I'm just mentioning two studies here, one of 175 male patients with elevated prolactin, and as you can see, only a minority of those 5 patients had gynecomastia. Slightly larger number in the Milan study from Anna Maria Kalau, 4 of 7 patients. But more typically in prolactinomas, we see, as this audience knows, symptoms like headache, if it's a microprolactinoma, reduced libido because prolactin interferes with GnRH and typically leads to reduced testosterone and estrogen in females, erectile dysfunction, and infertility. So why does this patient have gynecomastia? As Dr. Beals mentioned, this gentleman had one of his social habits was to use marijuana, and this is by no means figured out on a etiological scientific basis, but there is some homology between one of the components of cannabis, 9-delta-tetrahydrocannabinol, and estradiol. And some people have proposed that this substance can actually bind the estrogen receptor. And actually, if you look at the literature, and this is one review from Journal of Clinical Pharmacology a number of years ago, marijuana has actually a lot of endocrine effects, certainly at the level of the hypothalamus via the CB1 receptor, but also effects at the level of the testes to interfere with spermatogenesis and Leydig cell production of testosterone. So be warned, boys. It has a suppressive effect on reproductive hormones, prolactin, growth hormone, and thyroid axis, and a lot of this is derived from animal studies, but in humans this has been pretty inconsistent. So there's a lot of literature dating back to the sort of Vietnam War when use of cannabis was fairly frequent, and yet a lot of these GIs did not actually have a lot of endocrine problems. So it seems that a lot of the responses in humans, at least, are lost with chronic administration. But we believe that the cause in this chap may indeed have been his marijuana habit.